A mighty good morning to you. And of course, welcome. You are joining us live at the Jubilee Insurance Center. Today we're championing hope. We're talking cancer. We are figuring out what the numbers mean, what early intervention could do to save lives and, of course, improve quality of life for so many Kenyans and people around the globe. And we are doing it courtesy of an amazing audience here at Jubilee. It's a pleasure to be here. Eric, I know the conversations around the by-elections are still, hot. And, of course, if we do need to jump in, we will. But for now, we are championing hope. Before we get into anything else, I want to invite some of the people who will be taking us through our program today. And of course, we have a medical professional going by the name of Professor Mansour. He is, of course, an expert in his field. He will be with us on stage. We also have CEO here at Jubilee, that is Njeri Njomo, who will be on stage as well, walking us through these conversations, giving us a little bit of guidance, and of course, making it as engaging as possible. The idea is to leave here a little bit more informed, a bit braver, more knowledgeable, and of course, feeling like, you know what, I spent my Friday morning really, really well. Hashtag continues across all social media. Keep engaging us, ask your questions, and we'll be more than happy to answer. In the center as well, we have an amazing audience. I'd asked earlier the expectations that we have from this conversation today. When we say that we are championing hope, what does that mean? And I know we had that discussion, but I'll ask because it's important for our audience as well to know some of the expectations that we have here. If you have anything that you want to leave, having gotten from this conversation today, what is that one thing? If you get an answer, maybe some inspiration, maybe some hope, there's something that's on your mind. I'd seen quite a number of hands earlier, but let's go into the audience. Expectations for today. Mnataka utoke hapa na nini? Yes?
I'm Jambo. Good morning, everyone all over the world. My concern is, what is Jubilee doing to ensure that early intervention or detection is done from the higher in society in terms of earning and the lower, because costs for wellness tests are very prohibitive. So before somebody comes for treatment in the hospital, it's already reached a higher level. What is Jubilee doing about it? Number 2, supplements. There is a lot of supplements in the market. How can it be controlled or ensured to the patients that this is the right supplement for maintenance and control after cancer diagnosis? My name is Alfred Weku. Thank you so much.
Alfred, before you give the mic, the color of your ribbon, what does it represent? I've learned so much, by the way, in just the few minutes that I've been here, as far as different ribbons, different colors, different cancers. Tell us.
Yeah, I was given a color, and I seem to be colorblind. I asked for blue, light blue, which represents prostate cancer, and I believe this is blue. Thank you.
Okay, thank you. Thanks, Alfred. But thank you for giving us your expectations as well. Blue, green, I mean, who really knows colors, right? But we'll get a few more expectations as the day goes along. Maybe we did hand over to the event, but I see your hand, and we'll come back to you as the event goes on. But we need to get into the conversation right now. So I'll hand over to the MC to give it over to Professor Mansour, and of course the CEO. Hashtag, of course, continue. Endelea kuuliza maswali. Hands up in the audience, hands up at home, on YouTube, live, everywhere. And we will answer those questions as best we can. You're in a better position to tell me of all the expectations. I know zilikuwa nyingi. But we'll be back. We'll continue giving this coverage as the day goes on. For those of us who are on Nation FM and on NTV, we will keep it live.
Sorry for that. Thank you so much for that lovely introduction. My name is Dr. Brian Kariuki, and I have the singular honor of welcoming us all to the Jubilee Complex here at Kilimanjaro Road in Upper Hill, and most of all, to invite to the stage our CEO, Njeri Njomo, also Principal Officer, Jubilee Health Insurance, And the reason that we're calling her onto the stage is one, we want her to tell us why we're here. Just paint a picture, these covered conversations. What do we want to talk about? What do we want to achieve? And I'm sure she'll do a good job at that. Njeri Njomo, welcome.
Thank you, Dr. Brian, and good morning, everyone. And to our audience here who are mostly Jubilee customers, we want to appreciate you for your patronage and coming to have this conversation. And to our live audience, thank you for joining us, because it's a conversation we believe we should have. So, covered conversation. What brought this about? For Jubilee, we sit in an interesting intersection. Jubilee Health Insurance is a leading health insurer in Kenya and in the region, but that puts us in an interesting spot. It means that we are able to see health trends quite well. We also are in the middle of health financing, because health insurance is a form of health financing. But also we get to see the human emotion that often goes and is associated with health. So what we want to be able to do through this Covered Conversations platform that will continue to happen frequently is to bring to you, our customers, and to Kenyans, a research-backed conversations on all matters health and insurance. We want you to know the facts, remove the myths, the old wives' tales, and have an opportunity to have the facts. So why are we talking about cancer today? Today is the inaugural Splat Day, where we are starting Covered Conversations, and we start with cancer because we believe that this conversation must bring hope, but also it must be done honestly. We want to demystify cancer, but we also want to reduce stigma. It is not a curse. And the research will show us that. But we also want to empower you, because with the knowledge, you can take better care of yourself. This conversation is not only for those who already have a cancer diagnosis, it is also for those who don't. Because we don't want to only deal with insurance, where we are taking care of your curative care, where we're only treating. We want to do prevention, and we want to support you with it. But even if you do get a diagnosis, we want to make it possible for you to know how to deal with that. Today, physically here, we will have Social Health Authority outside, where you who are physically in the audience can engage and be able to find out more about the enhanced cancer care package they're speaking to, confirm and clarify any other issues, because SHA is one form of health financing, health insurance, then we'll normally pick up from there, but we look forward to having more of these conversations today. But I have the absolute pleasure of introducing to the stage Professor Mansoor Saleh. He's a medical doctor, and Professor Mansoor began his early education in Aga Khan school system in East Africa, and we have a shared heritage because Jubilee Health Insurance is within the AKFED, the Aga Khan Fund for Economic Development. We are part of the wider Aga Khan Development Network, and therefore he began his schooling in Aga Khan school system in Africa, pursued his medical degree at the University of Heidelberg in Germany. He completed his doctoral research at the prestigious Max Planck Institute of Medical Research in Heidelberg. Dr. Saleh went to receive his internal medicine training at Henry Ford in Detroit, Michigan, followed by a subspecialty training in hematology and oncology at the University of Alabama Comprehensive Cancer Center. At UAB, he served as a tenured professor of medicine and pathology and was the director of the First in Human Early Drug Development Program. His research and clinical work have centered on the targeted therapy of cancer, with a strong focus on translating novel agents from bench to bedside. In January 2022, Dr. Saleh returned to East Africa to join the Aga Khan University, Nairobi, where he is currently serving as the founding chair of the Department of Hematology Oncology and the founding director of the Aga Khan University, Nairobi Cancer Center. Ladies and gentlemen, please join me in welcoming Professor Dr. Mansoor Saleh to the stage. Please clap until he joins me here. Thank you.
Jerry. Thank you, Asante. You know, I've talked to many audiences. I've never talked at an insurance company. So this is also a first for me. Although I must admit, I have another insurance that I carry, but I wish I carried Jubilee because I believe they do have good coverage. But we will challenge them today as to how good their coverage is and be honest and a transparent discussion. I gave a talk show a few months ago to the Somali community here in Nairobi, and Jerry was there, and she felt like we should do this for the customers and the participants of Jubilee Insurance. And I think it is easy for a physician to talk. I'm looking for customers who have cancer. That's how I pay my bills. But when a patient who has survived cancer, gone through the trials and tribulations of cancer, when they talk, it is much more honest and much more transformative. So we have three individuals who really are, in many ways, cancer survivors, and who are really going through the journey, will give you their stories, and we will ask questions, and then you can ask them questions, because through their lives, you will learn what to do better for your own life. So I would like to at least introduce to the stage, these are all three patients of us at Aga Khan. Milia Ksenia is here. When I first saw Milia, she was in crutches, in severe pain. Today you see her, she's walking, really, she could go on a walk show and have a good dress on her. But Milia, welcome. Yeah. I'd also like to introduce Margaret Kiragu. Margaret is also a breast cancer survivor. And then also Daniel Njuma. Daniel is an esophageal cancer survivor. And I know there are many survivors in this audience. Next time we have a presentation like this, we will get more of you to talk, because I heard about triple-negative breast cancer, I heard about prostate cancer. We'll talk all about that. When I talk to my students, my residents, my fellows, I ask questions. So I will expect to ask a few questions to the audience, and I hope the earlier you answer, the better we are, because we'll be sitting until late at night if we do not get these questions answered. So if we could have some slides, and then we'll have a talk show. Who has watched in the US the Phil Donahue or the Oprah Winfrey talk show? A few, okay. So I'm Oprah Winfrey for tonight. Yeah. If you take a picture of this QR code, it will give you a list of questions that reflect whether you have anxiety or depression. If you do that, you can score yourself. And my hope is that at the end of this presentation, your score of anxiety and depression will go down. We do this at Aga Khan University Hospital for every cancer patient who comes to see us, so that we can assess anxiety and depression at the time of diagnosis. And if you have a certain threshold level, we provide you counseling. That to me is a requirement of our care for cancer patients. Next slide. I came to AKU nearly 6 years ago. I left home. My home is in the US. Merely because of this statement by the Chancellor, His Highness Aga Khan, when he opened up the Heart and Cancer Center in 2011 with Mwai Kibaki. And he said, let me mention two investment areas that are most sadly shortchanged in the developing world: research and education. I came to Kenya to educate the new generation of cancer specialists. And I came to Kenya, as Jerry said, to do research. Because most research done in the West is with patients, Western patients, white patients, Caucasian patients. We are not white Caucasian patients. The drugs developed in the West may not work for us. They may work differently. And which is why we need to do research on our patients, on our diseases here in Africa. And I will show you some data. Next slide. So here we are. Oh, let's take the slide back because it's giving away the answer. Oh. So you tell me, what are the three things that differentiate a normal cell from a cancer cell? Three things. Only three. Very easy, simple. Three things that separate a normal cell from a cancer cell. It's all one word at a time. The doctor, I should get him last. If nobody speaks, he will come and bail you out. Anyone? Yes, go ahead.
Malignant and benign. Malignant is cancerous. Benign is the normal cell. As a psychologist, I also want to learn from you. Thank you.
You know, when I became an American citizen, you had to put your hand on the Bible or the Quran and you say the truth, the whole truth, and nothing but the truth. This was the truth, but not the whole truth and not nothing but the truth. One more answer. 3 words, 3 characteristics, 1 word each. The difference between a normal cell and a cancer cell.
Reproducibility, the rate at which they
proliferation, growth.
Also, we can talk about ability to invade other.
Invade, okay.
Yeah. And also, lastly, they grow by surpassing the body immune system.
Okay, we got 2.5 points. I applaud you for doing that. Next slide. So here you are. A tumor cell grows, proliferation, fast growing, faster than a normal cell. It invades, so it is invading the membrane, it invades into the bloodstream, and from the bloodstream, it goes and metastasizes. So a breast cancer cell from the breast will grow fast, become a lump, invade into the tissue, and then go into the bloodstream and lymphatics and spread everywhere else. So 3 things. Next slide. You see that cell? Here it is on the left-hand side, growing, growing, growing. Invasion into the bloodstream and metastasis. Next slide. So we then have a normal cancer cell that becomes malignant. It invades into the bloodstream, and then it can go to the liver, the lung, the bone. That is what takes the life of a breast cancer patient, or a prostate cancer patient, or a lung cancer patient. It is not the tumor itself. It is the invasion and the metastasis of the tumor to other parts of the body that takes your life. So having said that, what do you think is the best way to cure cancer? It invades, it metastasizes, what takes your life is metastatic disease. So to cure you, what should you do about cancer? 1 word, 2 words. Kill the cells? Well, that's good. Early detection. Jay talked about early detection. The best way to ensure survival for cancer, in cancer, is early detection or prevention. So when you talk about cancer, people are afraid of cancer. You know, heart disease is the most common disease in North America, in Africa. More people die of heart disease than of cancer. Cancer is number 2. But we don't seem to be afraid of heart disease. You get chest pain, you'll take some Panadol. Gets worse chest pain, you go to Aga Khan or somewhere else to say they can give you a stent or they can give you medication. You know, in my house of prayer, the Jamaat Khana, there are chairs for people who sit, who cannot walk, etc. And we give priority. Those people who have quadruple bypass surgery get the first row. They get a priority. Single bypass surgery, the last row. If you have chest pain but no bypass, you sit on the floor. So we give priority for those who could not sit on the floor. We put them sitting on the chair. So the people with heart disease, they come and show me, I've got a big scar from quadruple bypass surgery. We give them first row. We don't seem to be afraid of heart disease because we think we can manage it. But cancer, everybody's afraid of cancer. Why? We fear cancer because we think it can happen to anybody. Nobody's protected. We fear cancer because we think there's nothing we can do to prevent cancer. And most importantly, we fear cancer because we think the treatment is worse than the disease. Well, can we prevent cancer? Jerry talked about cervical cancer. Can we prevent cervical cancer? Raise your hands if you think you can. How? Anyone? Early detection is early detection, not prevention. Prevention is not making it happen. Can you prevent cervical cancer? How? Vaccination. How is it that a virus can cause cancer? But this was one of the first viruses we discovered that can cause cancer. The first virus that was discovered that can cause cancer was discovered in Kampala, Uganda. What virus was that? Jerry, I'm testing the knowledge of your Jubilee insurance people. What was the, let's see, go ahead. Epstein-Barr virus. It causes Burkitt's lymphoma in young children, identified by Dr. Burkitt at Uganda Cancer Institute in Kampala. It is a tumor that really grows within days. By the time the family can take the bus fare to come to Uganda, Kampala, the tumor has taken up most of the face. But it can be treated very effectively. Chemotherapy melts Burkitt's lymphoma like butter in the sun. But it is caused by Epstein-Barr virus. And the second virus that causes cancer is HPV, human papilloma virus, causes cervical cancer. Jerry, do we cover cervical cancer prevention, vaccination by Jubilee? Yes, we do. Now you tell me, in this audience, how many of you vaccinate your boys and girls against cervical cancer? Well, take away the boys. Let's talk about the girls. How many of you, I'm sure you're all parents, you have children, how many of you have used Jubilee coverage for cervical cancer vaccination to make sure that cervical cancer can be eradicated? Because cervical cancer can be eradicated by 98.6% by vaccination. How many of you tell me? You can raise your hands, and I will tell the TV not to look at you so that you don't feel embarrassed in the audience. Who has had their young girls vaccinated for cervical cancer? Abana. 1. 1.5. All right, 2. Jerry, we should do better, right? Cervical cancer, second most common cancer in America, in Africa, in Kenya, in Nairobi. 98.6% eradication by cervical cancer vaccination. We can eradicate it. I think Jubilee should start a program to be able to vaccinate our young girls and the boys as well, because they're the ones who spread the virus to the girls. So we should at least start with the girls in childhood age, adolescents, age of 12 to 16, vaccination. Even adults who are now moving from one partner to the other because the virus comes to you from the partner. So if you feel like you're changing a partner, you won't be protected, you can go ahead and be vaccinated as an adult. Possible. Yeah? So those are vaccination, prevention. Early detection we talked about. 3 cancers we can early detect. And I will ask Jay to see whether we are covering, Jubilee covers those. What are the 3 cancers that we can early detect? And if we do, we can really improve the cure rate. Anyone on this side? That's far away. Breast cancer. Early detection, how? Mammography, right? Number 1, breast cancer, early detection, mammography. Do we cover mammography? Okay, we passed Breast Cancer Month, October, we give you a big discount at AKU. How many of the women in this audience who are above the age of 40 have had 1 mammogram? A few, okay? You know, on Valentine's Day, the men take their wives far away, good night, great evening. Next morning they go and wash the dishes all over again. I would tell the men on next Valentine's Day coming up, February the 14th, treat your wife for a mammogram. And the wives who love their husband, treat your wife for 1 blood test that is the early detection of the most common cancer in men. What is that most common cancer in men? And what is that blood test that allows us to early detect that cancer? Prostate cancer, right? So the women should give a gift certificate for prostate cancer PSA testing to their men Valentine's Day. I think, Jerry, on Valentine's Day we should have a celebration. And we should really provide PSA testing gift certificates, mammography gift certificates, and the last cancer that you can detect early, It is number 3 most common cancer in Africa. No, cervical number 2, breast number 1, number 3, colon cancer, colonoscopy. I can assure you, I can predict only 2 people will stand up to say they've had a colonoscopy as a preventive measure for colon cancer. Tell me, you prove me wrong. Who has had a colonoscopy as a preventive measure for colon cancer in this audience? We're about 400. 1, 2, 3, 4, 5. So you proved me wrong, but I would think that if you really want to protect yourself against colon cancer, colonoscopy. Do we cover colonoscopy in Jubilee as a preventive measure? We do. All right. So I'm going to talk to you about the experiences of my audience here. So Margaret, did you ever, how old are you today? You know, I think we should declare your age. Is it okay to declare your age? All right. She says yes. Somebody says, some man said yes. Margaret, how old are you today?
I'm 45.
45.
Yes.
When was the first time you had a mammogram?
At the age of 43.
43. What is the age at which we should have a mammogram in Africa? In America, we said 50. In Africa, 40. We're at a higher risk than the West. Our first mammogram should be at the age of 40, unless we have a family history of breast cancer. So you had your first mammogram at 43.
That's true.
Okay. What happened? Why did you have a mammogram? Did you feel unwell, or did your husband on a Valentine's Day give you a gift certificate for mammography, or what happened?
I actually had it because I was unwell.
You were unwell.
Yes.
Tell me more.
So what happened is that I'd noticed a lump 3 months that I kept postponing to go for the mammogram. So my regular visit to the doctor just to inquire why the lump is there, that's what sent me to the mammogram regularly.
How long did you have that lump that you detected, and when did you detect it? What were you doing that you detected the lump?
I had had the lump for 3 months. That's in the year 2023, in January, I detected a slight lump. I let it pass me by. Then gradually, in March again, I detected it was becoming bigger.
Bigger. You talked about proliferation, growth in size. 3 months. You know, when I came to Kenya, I learned 2 words. One is noted. When you send an email to somebody, they say noted. I have no clue what that means. Did that mean they paid attention? Will they do something about it? Noted. Yeah. The second thing I heard about in Kenya is kesho. Not today, kesho. Yeah. So this was kesho for 3 months. Yeah. So it grew bigger, and then what happened?
It grew bigger, and I mentioned it to my spouse,
Okay.
who told me to go and get a mammogram done.
I see.
But being the lady that I am, I postponed it again.
Even postponed even further. Yeah. Double kesho. Okay.
Yes, until when I noticed the lump had now advanced to under the armpit.
Okay. And we'll explain that later as to how it goes to under the armpit. So, Milia, you had a different story. Tell me about your story.
Mine is interesting, different from hers.
How old are you, Milia?
33.
33.
Yeah.
When your symptoms began, how old were you?
32.
32, a year ago. Go
Yeah.
ahead. Okay.
And I mean, when you're talking about the age 33, 32, quite young, from what we know, you always tend to think those between the ages of 20, let's talk 25 to 35, we are rather more safe, but it's quite different. But then it took a whole year.
Now tell me what happened. What
Yeah.
was happening to you?
So last year around that May, just my normal routine, waking up, dressing up, going to work. So I was at the sink doing, brushing my teeth. But then I developed a very sharp pain on my lower back. So that is where the journey started. Went to the hospital, had an x-ray, nothing was seen. Then was given muscle relaxant. So for several months I was on muscle relaxant, but the lower back pain never went away. The only thing that kept on happening is every month it kept on progressing quite differently. So this month I can't bend, the next month I can't put on my trouser, the next month I can't stretch, the next month these chairs are quite a task for me to make a move or so. So that went on until November.
And you started in March, you said? May to November.
Yeah.
Pain, can't move, now obviously needing nearly a walker to walk. And you went to many medical doctors.
Yes.
What did they say?
So...
Did they examine you or just looked at you and said, you've got pain, Panadol, this, that?
So, I will go for the visit, then they will tell me muscle relaxants can do. But then the very last doctor had told me, he examined me, then told me, I think the problem I see with you, that's a lumbar spine problem. So before we start off on anything, I think a physio will do.
Physio. We went from Panadol to having just take it easy to physio now.
Yeah.
And once in a while an x-ray.
Yeah. So he said before we do an MRI on anything, I think you should just start a physio. Now the physio made it worse, because the first session I did, thanks to God, because it would have broken my bones. Yeah.
So Margaret was talking about breast lump. Did you have a breast lump?
So for the breast lump, from May, I never felt anything.
Never felt anything?
Never felt anything. In fact, by the time I had been admitted at the hospital, the doctor is telling you, have you ever felt any lump? And I'm like, what are you talking about? Then he said, let me examine you. We felt the lump together.
See? Most of us go to a doctor, he looks at you, smiles at you, you feel good about it, they give you a bill and you go home. Any doctor who does not examine you is not worth the salt on his face. So I think we have a responsibility. When you pay as much as you pay for a doctor, make sure that they examine you, they undress you, they really looked at your lymph nodes, your breast examination, your abdomen. That is our expectation. Often we say, well, it was an easy visit, paid the bill, life goes on. This is what happens. By the time I saw Milia at the Aachen University Hospital, a big breast mass, metastasis, remember I talked about spreading all over the body. And let's go very quickly. Can we go back the slide? And before we get to the slide, Milia said she wakes up in the morning and brushes her teeth. Who brushes their teeth before putting makeup in the morning? Do women put makeup first and brush the teeth, or which is the way you do it usually?
I mean, the brushing of the teeth comes
first. You brush
first.
Brush your teeth first? Okay. Let's continue until we get a scan. There's a scan, I think it's about, keep on going. Keep on going. Keep on. All the way until you get to a scan. One more down, two more down. One more, one more, one more, one more, one more. Here. This is not Milia's scan, but it was a scan that is a PET scan. Once in a while, you ask Jubilee to order a PET scan, and they approve it. What is a PET scan? PET sounds like a cat, a pet. What is who has had a PET scan? Ever? 1, 2, 3, 4. Tell me what is a PET scan. Anyone? Go ahead. In a very short way.
A PET scan is one of the series of tests after diagnosis of cancer.
Well, what is a PET scan? What does it? Yes.
It's It is to determine the growth of cancer if it has spread from the central place to any other place. That is what they're calling metastasis. If it's grown to another area.
All right.
Thank you.
Never have a test that you do not understand what you're paying for. It is the truth, but not the whole truth and nothing but the truth. I can get a CAT scan, it can tell me something is spread. A PET scan is any cell that is dividing takes up glucose. So we give you radioactive glucose into your arm, into a vein. Anything, any part of the body that divides quickly picks up radioactive glucose. So here we are. It's a PET scan. Anything that is dividing is picking up glucose. What is the most active dividing cell in the body? They will take up glucose. You get that, you get free lunch, free dinner, free Valentine's Day dinner with me. Which is the fastest consuming organ? It takes up glucose because it's dividing all the time. It's doing something all the time. Yes. Pardon? Not liver. Look, brain. The brain takes up glucose. If thinking caused weight loss, we'd all be thin. Yeah? Unfortunately, it does not. But look at it. The brain is always thinking. It's taking up radioactive glucose because those neurons are firing all the time and they're dividing to be able to think. So we tell a patient, when you come for a PET scan, don't quarrel with your wife because your brain will be hotter than hot. So the brain is always hot. The bladder is hot here because that's where you excrete the radioactive glucose. But everything else in this body is hot because of cancer. This was nearly what Milia's PET scan looked like. PET is positive emission tomography, radioactive glucose to sites that pick up glucose because they're dividing. Look at this. Everything is nearly black. The liver is black, the bones are black, the legs are black. This person cannot really walk and they've got metastatic disease in the liver. What do you think? How long will this patient survive, you think? With all this disease in the body? Take a guess. Pardon? 3 months. Good choice. Anyone else? 1 year? Okay. Very optimistic. This is a PET scan of the same patient after treatment at AKU. Look at the PET scan. This PET scan is like your PET scan. The power of research. Because this patient's tumor, very much like Milia's tumor, had a target which was responsible for the growth of the cancer. You were able to block the target and you take away the growth factor from the target and all the cancer is gone. Look at this. Just the brain is hot and the bladder is hot. The liver is clean, the spine is clean, everything. This is the sign of hope. This is why we do research in Africa, to discover the targets on patients, African tumors, and we can treat. The drug called hope is this. So those of you in the audience who have cancer should realize that every day we have new discoveries, and Jubilee covers most of them, and that there is always hope because we will work hard on your behalf to find a treatment. If this can happen for this patient, very similar like Milia, it can happen for everybody else. Yeah? So Daniel, you don't have breast cancer. You don't even have breasts. Do you have breasts? Probably not. Yeah? Okay, he doesn't have breasts. He doesn't. Well, do men get breast cancer? How often? All the women said men get breast cancer, but the men were quiet. Yeah? 1 in 10 breast cancers happen in men because they have breast tissue as well. The treatment is the same. Okay? But Daniel, you don't have breast cancer.
I don't have a breast cancer.
Sounds good. Have you examined your breasts?
Not.
No, not. We'll do that later. But you had something going on in your life. Tell me about that. And when was that?
Well, what I have is esophageal cancer.
Well, don't give them the answer. This is a test. So tell us what happened to you when you were having symptoms.
In October last year, it's only my son who realized that every time I was taking a meal, I would request for water. I'd not noticed, but at one point he told my wife, you've not realized Dad always asks for water nowadays when he's eating. So come November, I traveled for work. I was in Kitale. And that is the first time I choked on food.
Let's say he's drinking water to get the food down. He chokes on the food. What would a layman think is happening? When you eat mishkaki, yeah, nyama choma, it's choking you. You got to drink a lot of fluid to shove it down your esophagus. What do you think is going on? A layman's thought. Anyone? Pardon? It's eaten too fast. Anakula chakula fast. That's possible. Daniel, why unakula chakula fast? No, wasn't the case. What is happening? When this happens to you, you've got to think about something. Daniel, when that happened to you, didn't you think something was not right with you in some organ? Did you think about it? It was your son who said you're drinking water to really lubricate the food. Did you think something was stuck, getting stuck or causing a blockage?
It never crossed my mind. It was because it was very mild. I just take water and then everything goes well.
All right. Who can make a diagnosis for me? You're not a doctor. You don't have to be like me, but you can make a diagnosis. Tell me the diagnosis of this patient who cannot swallow a piece of mishkaki because it's getting stuck. Pardon? One answer. No one? Jubilee. We have not educated our people. Go ahead. Esophageal cancer. Do you have esophageal cancer?
Yes.
What is the esophagus? The esophagus is the food pipe where your food goes through before it gets to the stomach. You can imagine, within about 30 seconds of eating, you cannot swallow. It may be here, but he can't swallow. It's stuck in here. He had a tumor in the esophagus that was blocking the food from going down. How long did you have those symptoms?
For about a month.
A month.
Yes.
Okay. So what happened? And then, so you had to drink water, etc. Did a time come when food would not go down at all?
Until that day, I was in the field and I struggled. I was taking water and nothing was happening. When I just stood up, because I was feeling very uncomfortable, it came out with a lot of pressure. Everything that had gone into my tummy just came out with a lot of pressure. And at that point, one old man just told me, my friend, don't be embarrassed. We work with a lot of things in our bodies. I can tell you that day, the following day, I traveled back to Nairobi, and then the following day I went to hospital. And that is how my diagnosis came about.
All right. We have Daniel here who could not swallow. An all-wise man said, go and take care of it. What test would you do to determine he's got esophageal cancer? This is like medical school now. What test? Yes. Endoscopy. Wow. We should give you an extra premium courtesy for the insurance. Daniel, did you have an endoscopy?
Yes.
What is an endoscopy? Sounds like a bad word.
Can I really explain? I know some sample was taken. The first one I was told it was a small sample. That was not enough. Then I went for the second endoscopy. That is the point at which it was determined.
Yes, so endoscopy is a very small tube with a light at the end. It's got a little camera. We go down your throat into the esophagus. We can see what's going on. We can take a specimen. So in his case, if we look at the medical records, we see a picture of a tumor blocking the esophagus, which you know why the food cannot go down. So we take a biopsy. Turns out to be esophageal cancer. We'll talk about it in a minute. Not very common, but we see a lot of it in the northern parts of Kenya. We don't know where it's coming from. It may be the food, the environment. Many of us use charcoal to cook at home. Those pollutants, those tiny pollutants, can probably cause irritation of the esophagus and lead to esophageal cancer. We'll talk about it. So here we are, endoscopy, biopsy, diagnosis, esophageal cancer. Did it spread? Did it metastasize like this PET scan? Was it spread anywhere else? It was just here?
It was just here.
Just here. What did the doctors tell you? Can they cure you?
Yes, they told me they can cure.
If you have esophageal cancer, you want to be cured, there are two options. Very logic. You know, medicine is very logic. You've got this food pipe. It's looking like a pipe. It's got a tumor in the middle. Two ways you can cure that tumor in the middle of this pipe. You tell me one way to cure it. It should be simple. It's difficult for him, but a simple answer. You've got a little tumor in a food pipe. It's like your pipe at home. The water's going down the drain. It's getting stuck. What do? Fun? You get a new pipe. That's possible, yeah. You cut the pipe and just solder the ends again. Surgery. Did they say surgery would cure you?
Yes.
Yes? In his case, surgery would be uncurable. Why? Because the lymph nodes were also positive. Let's go back to the beginning. On my slide set. The tumor had not only spread in the esophagus, it had gone to the lymph nodes next door. Margaret said her lump in the breast had gone to the axilla. Those are the first lymph nodes to which a breast cancer spreads. In the case of esophageal cancer, the lymph nodes next to the esophagus were involved. If you cut it out, the cells have already spread. You will not heal, the tumor will come back. And that was the problem with Daniel's cancer. We'll come to it in a minute. I'll show you this slide. It's a very good video that I want to show you in a minute. So in his case, the tumor had gone to the lymph nodes. Surgery certainly would make money, but would not provide cure. The treatment for locally advanced esophageal cancer, where the tumor is spread to the lymph node, is what? What did you get?
Come again?
We did not do surgery for you. What did we treat you with? Your esophageal cancer. What did the doctors do for you? They did not do surgery initially.
Okay, initially they told me I would have a surgery. That was chemo radio.
Correct.
Yes.
When you have locally advanced cancer of the esophagus, to shrink the tumor before we do surgery so that cells have not escaped outside, we give you chemotherapy and radiation. Is that what you got?
Yes.
And then after the chemotherapy and radiation, we did surgery.
We did surgery.
We'll come to that story in a minute. Yeah. Margaret, did you have chemotherapy and radiation before you had surgery for your breast cancer?
Yes, I did chemo. Then after the chemotherapy, that's when I did my surgery, then radiation, then further chemo.
So logically, right? Let's say you have a breast. A breast is like a balloon. You've got a tumor in there. Why didn't they just take out the tumor?
The tumor had advanced.
Had advanced. Why?
Late entry into the hospital for checkup.
Because we waited too long. 3/4 of breast cancer in Kenya come to me like Margaret. Locally advanced from the breast to the axilla, sometimes, like in the case of Milia, metastatic. In America, 3/4 of women who come to me with breast cancer have local disease, curable disease. We want to transform the story of our women in Kenya who present with 3/4 locally advanced disease and metastatic disease to become really local disease. And the only way to do that is through mammography. So those of you who are 40 and above, take it now. Don't wait for the next October. Get a mammogram. Maybe you need an ultrasound. Early diagnosis. Do not be like Margaret's situation where she did pick up early enough. It was not metastatic, but it had spread to the lymph nodes as well. And before the surgeon could do surgery, he had to give you chemotherapy. To be able to shrink the tumor as much as possible so that they could try to conserve the breast. Were they able to conserve your breast? Not able to conserve the breast? Right? So we had to have a mastectomy to be able to remove the breast because we could not shrink it all. However, after chemotherapy, and they took out the breast, was there any disease left behind when they removed the breast? Do you remember? Can we have the mic?
Yes, I do remember. There was no trace of disease.
No trace of disease. If we give chemotherapy before we do surgery and there's no trace of disease, that person is really cured. We have to remove the tumor because there may be some cells left behind. But in her case, there was no trace of the disease. But they still gave you radiation to the breast.
Yeah, they did give me radiation because the lymph nodes, part
The
of
lymph
it, were
nodes were
affected.
positive,
Yes.
and the tumor was quite big. So despite surgery and no trace of disease, we still have to follow with radiation to the axilla and to the breast. You can save yourself all that by early detection by mammography. And where are you today? Are you cured?
Yes, my PET scan was negative.
Her PET scan was like the one on the left. Yeah? So here's a person who really was at the edge of survival. Localized breast disease, T4, T3, big tumor, more than 5 centimeters, positive lymph nodes, got chemotherapy, shrunk it all, no trace of disease, had surgery and radiation, it was all gone, and she is cured today. Are you taking any medication today?
Yes, I'm on hormonal treatment.
Why are you taking hormone treatments? Who's making money from giving you hormone treatments? Why do you need hormone treatments?
Well, I will do that for the next 5 years as advised by the doctor. This is just to control because I was diagnosed with HER2, which is a receptor that can advance anytime.
So it is not
later.
that the doctor owns a pharmacy wants to give you pills for 5 years.
No.
What is ER/PR in breast cancer? Estrogen receptor. What is estrogen? Women should know this. Men should help them. What is estrogen? Estrogen is the difference between Daniel and Melia, right? The female hormone. As a result of the female hormone, you develop breasts, you have menses. Estrogen is a growth factor for breast cancer cells because the breast cancer cells have a receptor like a little mouth through which they are fed the estrogen makes the cells grow. So in Margaret's case, because her tumor had the estrogen receptor, even though surgery was done, radiation for local control, there may be a few cells that have escaped. The only way to kill those cells that have escaped is to starve them of estrogen, so give her a medication that blocks the receptor. Yeah? So which is why when you have a tumor, breast cancer, always ask, is it estrogen receptor positive? If it is, you can block the growth of the tumor with an anti-estrogen. There was a young lady in the audience who says she's got triple negative. What is triple negative breast cancer? Milia, do you know what is triple negative breast cancer? I hope you do. What is triple negative breast cancer?
To be honest, I'm more conversant with the one she said because that was what I was diagnosed with. Yeah.
Triple negative breast cancer is ER negative, PR, progesterone receptor negative, and HER2 negative. Those are 3 receptors through which a tumor feeds itself. So if you are triple negative, there is no blocker we can give you. We are dependent upon giving you chemotherapy. However, there is one thing we can give a triple negative breast cancer patient. So that lady who had triple negative breast cancer, what treatment can we give a patient? You can give surgery, you can give chemotherapy, etc. There is one thing we have not talked about. What can give a patient, we can even do it for Daniel's esophageal cancer. When you have triple negative, you have no receptors. There is no mouth that you can pick out, that you can block. You give chemotherapy, it does not work. What other ways are there to treat triple negative breast cancer? The lady with triple negative breast cancer, TNBC, do you know the answer? She's smiling. Okay. What is the difference between an HIV and AIDS patient and me? What is the big difference? Sure, HIV patient has a virus, and you develop AIDS. What is the difference between the AIDS patient who has AIDS and me and you? Immunity. In AIDS, the virus destroys your immunity. You are immunocompromised. The healthy patient has an immune system. We all have an immune system. So why does our immune system not fight our cancer? Why doesn't it let Daniel have esophageal cancer, and Milia and Margaret have breast cancer. You would think the immune system would fight that cancer. Why not? You get this, you take dinner. No, you'll have to take me out to dinner. Why not? Why doesn't the immune system in Margaret and Milia's case destroy the breast cancer? It's a foreign cell, proliferating, invading, metastasizing. The answer is, Margaret and Milia's breast cancer cell looks like the breast. The immune system says, this is part of me. I'm not going to fight it. But we know today that tumors make a substance to block our immune system. So we have new drugs called immunotherapy that activate our immune system. So the young lady who has triple-negative breast cancer, if her disease comes back after failing chemotherapy, surgery, radiation, no other drugs available, we will give her immunotherapy to activate our immune system to fight our cancer. 30% of cancers today require immunotherapy to fight the disease. Do we cover immunotherapy in Jubilee? Some cases, think about it, very expensive. But that is one way to activate your immune system. Yeah. So Daniel, you got chemotherapy, radiation. Yes. You had surgery. Was there any disease left behind in your esophagus when they did the surgery?
Come again?
When you had the surgery, after chemotherapy, radiation, was there any disease left behind when they took out the esophagus, the tumor? Did they tell you there was disease left behind?
Oh, when I had chemo, radio, and then the surgery, actually at the point they were doing the surgery, there was no tumor. But I had to go through the surgery because my esophageal wall, because of acid reflux and all that, was damaged. And they say esophageal cancer is very unforgiving because of any leakages. So I still had to go through the surgery just to correct the wall. They take out the part that was already damaged. But
So
there was no tumor at the point of surgery.
So you can see that chemo-RT, radio, can cure the esophagus, but it is so damaged, the wall of the esophagus of this pipe is so thin, it can have leaks. Where when you eat food, it can break through the leak of the esophagus. So we have to do surgery. Yeah? So he's had surgery. So tell me, and each of you, Milia, Margaret, Daniel, when you got the diagnosis of cancer, what's the first thing that went through your mind? Margaret, what goes through your mind?
After my first, the news was broken to me, the first thought that went through my mind was, will I be able to survive this? Because of the stories that I'd had. When people go through the treatment, their health gets worse. There was also the aspect of the financial, that's the cost of treatment. So those were the two key issues that were bothering me so much at that particular moment.
Milia, what about you? You had metastatic breast cancer. Your PET scan looked like that. What went through your mind?
Margaret has talked about survival. My case, I'd never even thought about the survival. I started thinking, what did I eat? What happened? Who bewitched me? I mean, that comes out quite some time. In our family, there's no history. I sat down, started doing research on where I could have gone wrong. Then the survivorship part came later. I started Googling. I saw I had 6 months to live, started putting things together. Yeah, so...
Did it occur to you that you would die, that cancer will take your life?
I blocked my mind. I literally blocked my mind overthinking over that because I kept wondering about my 8-year-old daughter, what will happen? I mean, I just have a very young family. So anytime that thought would come up, I mean, from the Googling, that is eminent. I mean, it would come out immediately. So anytime I would think about it, I would block my mind, start thinking over any other thing. But then the only thing that always popped up is, where could this have come from? So anytime we'll sit down, I would research. I would start thinking of the food joints I had gone. I mean, I'm a gym person, so I would always research where did this thing come from? Where could I have gotten it from? And all that.
But when you thought about that you may not be here after all the Googles you did, 6 months, you looked at your young daughter, did you go to church more often?
Sorry?
Did you go to church more often after you got the diagnosis?
I mean, I prayed.
You prayed.
I fasted.
So,
Prof, there's a funny bit. The day the results came out, in fact, when they did a biopsy and all that, and I had to go for the results, I still believed I did not have cancer.
Really?
I totally believed. I remember the day I got the results, it came out 99.9%, and I was like, what is this? But then from that moment, I left the hospital, went home. But before we got home, we made a stopover with my husband, and we were to buy some groceries before we head home. I left him in the car, wandered off, looked for a church, cried for 1 good hour, talked to God, asked him questions like I was on Mount Horeb, then went back home.
What did you ask your God?
I told him, you never prepared me.
He didn't prepare you?
You did not prepare me.
Is there any pastor here in the
I told him, you never, at least you could have said a word. At least if it was in a family line, then my heart would have cooled down. I would have told myself, I mean, from the family line, I'm the chosen one, I'm the next one. But then there's no family history, there's nothing. I've always eaten healthy, so why me?
Daniel, you asked yourself, why you?
I would say I didn't ask myself why me, because my diagnosis came in December. Just before that, my mom was diagnosed in April. So for me, when it was disclosed to me, I felt like, so mom's one was just preparing me for this. But one thing that I can't deny is that I'd seen our preparation with the mom's medication and the finances that all around it. And it hit me like, for this, it's like I'm going to be on my own because the family is really exhausted. But again, immediately, the following day after diagnosis, I prayed. And one thing I asked God for is, I know this is going to be, it's going to be a journey, a long journey, but I asked God, whoever I'm going to meet along this journey, whether it's my HR, whether it's a nurse, whether it's a doctor, whether it's a customer care agent, along the way, just go ahead of me, speak to them. And I can tell you, people have been good to me.
It's interesting.
So good to me.
God answers prayers in many ways. So, can God make cancer go away? Wow. If that was true, you'd need no oncologist. I think maybe it's a different session. Maybe you're a priest here as opposed to an oncologist. I think, what gives you hope? In the middle of the night, when the breast hurts, and you say, oh, maybe it came back. What gives you hope?
For me, as much as we say God can heal, it is true God heals, but God works through the doctors. The research that has been put in place to try and prevent or cure cancer, and the information circulating in the media, and it's also readily available, and even a forum like this one, that gives me hope, because it means that the doctors are working round the clock in order to give us a solution. So it is not all lost. When you get your diagnosis, it's not something to look down on yourself. Don't ask yourself questions like, I've been doing things right. Well, many of us also, it's not in the lineage, so don't go looking back into your lineage, what could have gone wrong. So there is hope out there. When you do your PET scans, don't do one and just sit and relax. Keep going back after every year. The insurance is available for you to do that so that you can keep yourself into tabs with what is happening around you other than just wondering what's happening.
Yeah, clearly, self-blame is not beneficial. I don't think most of us do anything specifically to invite cancer. Now, if you're smoking, we know for a fact, right? The number of things that we do purposefully, intentionally, that really are high-risk factors. Smoking is one for sure. Yeah, heavy drinking is another one for sure. The number of things that we do that are toxic agents that we take, we think shisha, smoking through a pipe, is not toxic. It is very toxic. Even though that smoke goes to the water, what comes out of it is that non-soluble pollutants. That one session of shisha is like 100 cigarettes smoked. So we have to be very careful about the decisions we make. What gives you hope?
Prof, what gives me hope is we are in an era where the treatment has advanced. Sitting back and looking at, I'm a journalist. I have done stories about cancer patients. I never thought I would be one. And from the stories I did, we were at steps where we are not where we are today. So sitting back, I hope that I will see my tomorrow because of how the treatment has advanced. If you look at how it was years back and how it is right now, there are two different eras or seasons or times.
I agree with that. Yeah. Daniel, what gives you hope?
I would just echo that once again. The advanced kind of medication that we have. I have colleagues who are coming to the hospital to see me, and they were like, so your chemo seated. They were like, in their mindset, it was like a very complicated thing. They couldn't just think like they could even accompany me. And everybody expected me to lose hair and all that. I never lost hair. Actually, I lost just too much of my weight after the surgery. But during chemo radio, people were telling me, you are glowing. You don't look like somebody who's going for medication. So I think advancement in terms of what we are given, the kind of medicine that we are receiving, is what gives me hope that there's a continuous improvement.
So it is clear, one of the things I talked about is people worry that the treatment is worse than the disease. There's no question our treatments are tough. Chemotherapy is not easy. Once in a while you have a patient like Daniel who can tolerate it very well. But I think there is a price to pay. But we have today significant advances whereby the nausea, vomiting, the hair loss we cannot change. The hair will come back. Pick a color, it'll be the color of your hair when it comes back. So some of those things we cannot change. But let me go back to some of the slides, and then we'll go back to our audience, and I will take some questions from the audience. Let's go back to where I started. Here we are. So metastasis is when the cells from the tumor go to the bloodstream and spread. It goes to the liver, lung. So people say, I got biopsied, they had cancer in the liver. So I had breast cancer 3 years ago, now I have liver cancer. That's not true. You have liver metastasis from the breast cancer that was removed 2 years ago. Because the cells in the liver look the same as the cells in the breast cancer a while ago. Next slide. Okay, let's play this video. It's going to tell you about metastasis, what metastases are. Okay, if it does it work? Just press in the middle, see if it advances. No? Okay, we'll come back. Next slide. So here's a mammogram. Only 10% of women can feel their lumps, like Margaret did. By the time you feel the lump, though, it is a little bit too late. Have a mammogram. You can see normal breast. There's a tumor that you could not feel. This is why mammography. It is uncomfortable. We're going to squeeze your breast. There's no way. We could have flattened the breast tissue so we could identify the lesions. So that's a mammogram. Next slide. Look at this. One more slide. If you have a small tumor, stage 1. Tiny tumor, less than 2 centimeters. The axilla, the green, are negative. See where we are, stage 1. 90% cure rate, stage 1. You want to pick up your tumor when it's stage 1. Only mammography can do that. Next slide. Tumor becomes bigger, stage 2. Margaret's case was stage 3, but it was a big tumor. Look at what happens. 80% response rate. Still a great cure rate of 80%. Next slide. Stage 3, no, let's go back. Stage 3, lymph node positive, which is where Margaret was. Stage 3, here. You've gone now to about 60 or 70%. You want to be up in the 90%, but still not bad. But if you come to me with stage 4, which is where Milia was, look at this. 15% 5-year survival. You want to be in the red bar, 90%, not in the blue bar. We still have people like Milia who will survive because we've got great treatments. But if you have a choice, you want to be on the left-hand side, yeah? Which is why mammography is very important. Next slide. Same thing with colon cancer, which is why I promote colonoscopy. Small tumor, stage 0, very tiny. It's like a pimple in the colon. You can't feel it. The colonoscopy will see it. You take it out, 100% cure rate. Stage 1, see it's a big tumor. It is going right to the orange membrane, has not gone through the membrane. Stage 1, 100% cure rate. When you come to a stage 3, it's gone to the wall, it's gone to the lymph nodes, the cure rate is down to 60%. And if you come to stage 4, which is where most Kenyans are when they have colon cancer, 15% cure rate. You want to be on this side, which is why early detection is very important, colonoscopy. If you're above the age of 50, you have to have a colonoscopy. You got to find a way to convince Jubilee to make it affordable. Because if Jubilee finds you here, they will save money too. Because if they get you there, they've got to pay for surgery, chemotherapy, etc., much more expensive. Easier for the patient, easier for the insurance company. Next slide. Who can tell me what this is? You probably have seen it, those of you who have cancer. What is this? Looks like a tunnel, a bed, expensive bed. What is it? Pardon? Not MRI machine? Yeah, looks like it. It's a CAT scan, right? You sit on this little bed. It goes to the X-ray machine. The circular pillow is an X-ray machine. The X-ray cuts your body into small slices. That's a CAT scan, computer-assisted tomography. Next slide. That's where you are. See, the CAT scan X-ray cuts your body in little slices. Next slide. And this is what the radiologists see. They see little slices of your body and can pick up the different organs, can pick up certain cancers. So that's what a CAT scan is, which is different from a PET scan. Next slide. So this is a normal X-ray, chest X-ray. The heart is in the middle. If you're a good-hearted person, go to the church very often. You've got a big heart, but that's not good to have. It's not good to have a big heart. Small heart is better than a big heart. Yeah. Air on the left-hand side, on the right-hand side. This is a non-smoker, clean lungs. Next slide. Smoker who smoked for 50 years, 2 packs a day. See this big mass on the left? Could be cancer, could be benign, could be TB. How do you know it is malignant? It is actively growing. You do here on the CAT scan, on that slice, you can see it right there on the top. So what test would you do to define if this is cancer or just TB? What test? We already did a CAT scan. The X-ray. What's the next test that your doctor would want to do? In fact, you should tell the doctor. Go ahead. Biopsy, but before the biopsy, next slide. We do a PET scan. See, it's hot. If it's hot, most likely malignant, and now, as we say, as we heard, biopsy. The biopsy will tell you cancer, no cancer, what kind of cancer, because there are many kinds of cancer. So that's a PET scan. Next slide. I want to show you this because this is the phenomenon that Jay talked about, research. This is a PET scan of a patient with a melanoma. It's a very aggressive cancer. Look at this. Everything red and orange and green is disease. The bladder is hot because you excrete the dye. The brain is hot because you're thinking quite a bit when you're getting your scan. The liver, the lung, all of it's hot. 2 weeks after, 2 pills a day, look at the PET scan. The heart is hot because that's normal. The 2 kidneys are hot. The bladder is hot. The brain is hot. All this is gone. All because of a pill that blocks a receptor on a cancer. That we can do here in Kenya. Same thing here. Look at this. All the bones are positive in this patient. 2 weeks later, look at this. Nearly all the bones are healed. The power of treatment. But early detection is much better than late diagnosis. Next slide. We have a research unit at AKU where we do research on patients in Africa to see what are the diseases in Africa that are relevant to us, what treatments do we use. And our motto is a drug called hope. Tumaini is our motto for our research program. Next slide. Next slide. Okay. I'm coming to an end, and I'll talk to our audience, and then we'll stop on questions. Yeah, it will cost, all right? We're coming to time. Last one. Okay, got 5 more minutes. Very quickly, if you want to know your fortune, you can go to church, talk to the priest. You go to the witch doctor next door. What do you do? If you want to know your fortune, what would you do? One answer, quick one. You only got 5 minutes. Pardon? You look at your palm, exactly. Here's the palm. So look at all of your palm. Make sure you have the right part. It's the right hand, not the left hand, because you might get the opposite. So the right hand is, this line, number 1, is your heart line. If you're a good person, a good heart, long line. Number 3 is your lifeline. My lifeline is very short, so I think it must be something wrong. So here it is, okay? But that is how we did it with your grandmother. You come to Arkan University in 2026, I take a drop of your blood and I will tell you a fortune. Next slide. Because on the 11th floor of AKU, Universal Center, we will test the genes in your blood and tell you a fortune. Whether you're predicted to heart disease, breast cancer, everything else. I'm taking the list of people who want to come and see me next year to tell you a fortune from a drop of your blood. Yeah? That's my last talk, and we will have... Oh, break. I see. Okay, fine. So I'll tell you a fortune after the NTV break then.
Thank you so much, Prof. I think that was incredibly insightful. It will continue to be so for the people in this room. The Q&A isn't over. I know there's still a lot of hands up, but I just wanted to say a massive thank you to all of you for listening in, for engaging online. We see the questions, we see the interactions. We have been building a culture of hope, basically giving information, making sure that we come from a place of knowledge and not fear and not, evasiveness as far as cancer is concerned. The more we know, the better suited we are to fight cancer, the better suited we are as a healthcare system, as insurers, and of course as patients and as the general public. It's a massive thank you from me, Mariam Bishar, and of course from the entire Fixing the Nation team and all of us here at NTV. Tupatane another time. For those of us here in the room with us, thank you so much. You're an amazing audience. It's been an honor to be a part of this conversation. Thank you so much. And thank you, Prof. Thank you, Jerry. Wonderful.